All right, today we're going to do some knee MRI cases. So the first one is a 14-year-old female with knee pain following an injury while playing football. This is a case from the UK, so it was probably soccer rather than Aussie rules football. Who's going to have a look at this case?
So that would be me.
Excellent.
This is a plain X-ray AP view, which demonstrates a linear osseous fragment projected over the intercondylar region.
Yep.
The alignment on this AP view is within normal limits. I'd like to look at the lateral projection. So on the lateral projection, there is a large hemarthrosis.
Yep.
And the linear osseous fragment over the intercondylar region is again seen. So this is highly suspicious for an acute fracture.
And what do you think it could have come from? Yep.
The donor site is a little difficult to appreciate. It could be like the intercondylar eminence. I think I'd like some cross-sectional imaging, though, to review this further.
Okay. And just before we look at the MRI, there's also just this curvy linear density out here as well, isn't there? And it's a little bit kind of bulgy over that medial collateral ligament over here. All right, let's go to the MRI. And I've got the sagittal PDs here.
So the sagittal images confirm the large hemarthrosis.
Mm-hmm.
And there's also an intra-articular body that we can see at the intercondylar region. This has both cartilage and cortical bone signal intensities.
Yes.
I can see there at the lateral femoral condyle that there is a defect of the cortical bone and the cartilage. So I think this is most likely where the donor site is. And so then I think I'd like to further review the FAT-SAT sequences to review for bone marrow edema.
Okay. I'll give you the coronals first.
So we've got quite marked high signal intensity at the lateral femoral condyle, adjacent to where the donor site of the fragment is.
Yep, I'll give you the axial PD FAT-SATs now.
And as well, there's high signal at the medial patellar pole, and the medial patellar retinacular appears to be disrupted. There's quite a lot of thickening and irregularity.
Yep.
So I think this sort of bone marrow edema, bone bruise pattern would be in keeping with a lateral patellar dislocation with an acute osteochondral fracture.
Excellent. Good. So you've described the osteochondral fracture of the lateral femoral condyle. What about the patellar cartilage?
I think we've also got a defect there as well. Full thickness.
Exactly. You can see the lateral patellofascic cartilage here is nice, and then suddenly it stops. So the median eminence cartilage has been lost, and so has some of the medial patellofascic cartilage right where you've got that large impaction contusion. So you've got a big osteochondral fragment has come off there as well. And as you pointed out quite rightly, the medial patellofemoral ligament / retinaculum is all torn out here. The mid portion and the distal attachment looks relatively preserved. It's mainly that patellar aspect of it. If we go back to we'll stay on the axials here. A good place to look for osteochondral or cartilaginous fragments is in the posterior joint. See that one there? And there's probably another one sitting over here. So there's often more than one. And obviously in this case, we've got clearly two big areas where cartilage has come off. So we're looking for more than just this one big one that we've spotted in the front. of the joint here, which we saw in our plane film. The one that was medial on the plane film over here is probably migrated posteriorly in the joint since then on the MRI, because I can't really see it over here. But if we go back to the plane film for a second, that kind of, we describe this as the slither sign. Often when you see these, longitudinal or curvilinear calcified fragments inside a joint, often that's the tip of the iceberg, and what you're looking at is an osteochondral injury, and that's just the small portion of subchondral bone plate which is attached to it. So we call that the slither sign. So anytime you see that, the patient really needs an MRI to look for the cartilaginous injury. When I look at this plane film, the first thing I would usually think of is what you said, a tibial spine avulsion from an ACL distal attachment pulling off, which is quite common in kids. But it turns out that this one is, a transient patellar dislocation. It's got the classic kissing contusion pattern of the medial patella kissing against the lateral femoral condyle. I would have liked you to have then spoken about the risk factors for patellar dislocation. Can you tell me about some of those?
So first one that you can probably see on this view is trochlear dysplasia, or femoral trochlear dysplasia, where you can get a shallow trochlear.
Yeah, shallow trochlear groove and small medial trochlear facet. What else?
You can get lateralization of the tibial tuberosity or patellar translation.
Yeah, so if we go down to the tibial tuberosity here and then keep our mouse in the same spot and follow it up, and then kind of measure that distance across to the groove, that should be, around 10 millimeters. This one's much larger than 10 millimeters. Anything more than 15 millimeters is probably abnormal, and 20 millimeters is definitely abnormal. So this one's probably at least 20 millimeters. So there is that abnormal lateralization of the tibial tuberosity, which is leading to predispose the patient to a dislocation. And then what would be the other thing related to the patellar tendon?
So patella alta and measuring the Insel-Salvati ratio.
Yeah, so you can see here that the tendon's quite long, isn't it, relative to the height of the patella. So there's probably patella alta as well. So those three, trochlear dysplasia, lateralization of the tibial tuberosity and patella alta, predisposing this person to dislocation. And it's quite common for these not to be recognized. All they know at the time is that they injured their knee, and they don't remember it being the patella being dislocated. And so you'll see a joint effusion. You may or may not see any osseous fragments on the x-ray, and then you go on to MRI and you're really looking for this kissing contusion pattern and the osteochondral injuries that help confirm that that's what's going on. In terms of long-term recurrence of it, the integrity of the the medial patellofemoral retinaculum is important. So have a good hunt around for all of the cartilaginous bodies, and particularly axials on the fat sats, because you're going to have nice differentiation between the fluid and the bodies. Kissing contusions we've mentioned. This was just to remind me to talk about that. So it's important not just in patellar dislocation, but in other things like hyperextension injuries or pivot shift injuries. You get these corresponding contusions that can really tell you what the mechanism is, and therefore what other injuries to look for. I mentioned the slither sign, so that's when you're seeing a little bit of bone, but there's a whole lot of the rest of the moon, the rest of the cartilage, which is attached to it, which you should then use MRI to look for. And this is just a summary of those things that we've covered in terms of patellar instability risk factors, the patellar height ratio, like Insel-Salvati ratio, I think the trochlear depth, and the tuberosity to groove distance. Technically, they say 20 millimeters, above 20 millimeters is abnormal. I reckon anything above 15 millimeters is very abnormal, and are predisposed to maltracking and potentially dislocation. All right, case number 2. So a 35-year-old female with anterior knee pain, quadriceps tendinosis. So someone's going to have a look at this one for me.
Yeah, I'll have a look. Okay, so sagittal PD fat strat demonstrates a thick synovial band within a suprapatellar pouch joint effusion.
Yep.
So yes, suprapatellar. The quadriceps and patellar tendons are intact. Which is also well seen on the coronals, superior to the patella.
Yep.
Extending from medial to lateral. There's a small amount of prepatellar edema. No high signal in the Hoffer's fat pad. And I'll probably just review the patella. The patellar cartilage on the axials.
Yep, sure.
There's no chondral thinning, and again,
Yep.
the thick synovial band is seen.
So what do you think this could be?
Yeah, so I think this would be most in keeping with a plica, but the exact type of plica I'm not entirely sure, whether or not it's a medial plica or a suprapatellar plica.
Okay. So the medial patellar plica is usually kind of down here, interposing itself between the medial aspect of the patellofemoral joint, whereas this one's up high. So this is the suprapatellar plica. So they can be they're really common, a suprapatellar plica. They're not always complete like this, and they don't usually get inflamed. This has got gross synovitis associated with it. In fact, I've got an ultrasound here which just corresponds with that location, showing the hyperemia and the thickening of that synovium. So this is suprapatellar plica syndrome. The quadriceps tendon itself, looks good. It's normal to have these kind of longitudinal striations within that quadriceps tendon. And on the axials, you'll see those as little dots. See these little dots in here? That's normal. That's fine. That's not tendinosis. What you're looking for is kind of an amorphous high signal sitting in there. That would be tendinosis. So this is definitely not a quadriceps tendinosis. This is all happening deep to the tendon itself, and it is that plica which is causing the issues. Excellent. That's good. Just to review the other synovial plicae of the knee. So you mentioned, the medial patellar plica. So that's usually this shelf-like synovial reflection which sits between the medial aspect of the patellofemoral joint, and you can see it's often associated with degeneration of the medial patellar cartilage. You can see that fissuring of the cartilage there. So you get this chondromalacia of the medial patellofemoral articulation in association with that. Usually, again, these are quite common. They're usually thin and don't cause issues, but sometimes they get thick and can cause chondromalacia. And then the third one is the infrapatellar plica, which runs through Hoffer's fat pad, and often looks hyperintense if it's injured. Fluid can track along it, or it can get strained in a knee injury. So they're the kind of three most common synovial plica of the knee and what can happen to them. If I just go back to the MR, you just mentioned this little bit of signal in front of the knee. This is pretty standard. Most people have a little bit of high signal directly in front of that. So I wouldn't necessarily comment on it unless it's quite gross. The other thing to point out on this is that often people will look at this anterior cruciate ligament and think that there's a sprain in there because it's got some high signal in it. And that can happen on the sagittal images. What you've got to do is always just have a look on the coronals and the axials if you've got them, and you'll see that what you've actually got is a anteromedial and a posterolateral band which are just nicely separated out with a little bit of fat and things between them. So they're actually intact and look pretty normal. So don't overcall sprain of the anterior cruciate ligament on the sagittal images. All right, next case. So a 35-year-old female, acute effusion and posterior pain after twisting injury, pain with flexion and rotation, meniscal tear.
Okay, so we've got high signal in this medial meniscus, and there's a small parameniscal cyst seen at the posterior aspect of the posterior horn.
Mm-hmm.
And then there's that oblique sort of high signal tracking through that posterior horn. It's very ill-defined. It's tracking down to the inferior articular surface.
Yep.
And then looking at the anterior horn.
Yes.
It looks quite truncated, missing the nice triangle point.
Yep, so the inner free edge is missing, isn't it?
And so then as you're scrolling along, I think we can see then this displaced fragment sitting in the intercondylar region.
Yeah, I agree. So it kind of joins up with that anterior horn of the medial meniscus and runs through the anterior intercondylar recess in front of the ACL here, and then a lot of it kind of sits above the anterior root attachment of the lateral meniscus, but it's very much arising from the medial meniscus. If we look at the coronal images in the medial meniscus, again, you can see the body is truncated as well. Similar to that anterior horn, you've got truncation of that inner free edge. Kind of like a bucket handle tear, isn't it? But a discontinuous one.
Yeah.
So it's kind of started in the medial meniscus body and then, cruised around the anterior horn and then cut off and then flipped across. Anything else on this study that you would comment on?
So then there's quite a lot of high signal in the opposite, the lateral meniscus as well.
Yep.
But there's no disruption of the articular surface. So I think this is most likely a chronic intrasubstance degenerative change.
Yep, I agree. There's no signal going to an articular surface, so we can't call that as a tear. Nice. And then some people often point out the anterior root of this lateral meniscus. It's quite common for it to have a little bit of signal within it like this. Often it has a striated appearance. It can be, in this case, it's a little bit ill-defined, so it could be degenerative as well, but that striated appearance, anterior root of the lateral meniscus, is very, very common. But yeah, as you said, there's mucinous signal within this lateral meniscal body, but without a discrete tear. What about this in the proximal fibula here? What did you think of that lesion?
I thought we have a well-defined lesion that's
Yep.
high signal on the fat sat,
Mm-hmm.
and then this is sort of intermediate signal here on just the straight PD.
Yep.
I thought that this was most likely a little cyst.
Okay. Would it be common for a cyst to have this black signal at the back of it and then this high signal in the front of it? And what is that effect called?
Oh, is that your chemical shift?
Yeah, that's chemical shift artifact. So this lesion kind of follows the same signal as cartilage, doesn't it? It's kind of intermediate on the PD and then very bright on the PD fat sat. And that chemical shift artifact is quite commonly seen in enchondromas or low-grade chondroid lesions. You'll know about it from fatty lesions as well, but this is clearly not fat because it's still bright on the fat-saturated images. But yeah, this is quite typical of a low-grade chondroid lesion such as an enchondroma to have that chemical shift. So if you see that chemical shift with a T2 or PD hyperintense lesion, then think about a chondroid lesion. And obviously they're very, very common. And you know about how to report those, and probably best to say a low-grade chondroid lesion such as an enchondroma, just because we know that sometimes low-grade chondrosarcomas can look like this. I try not to mention low-grade chondrosarcoma in the report though, because it scares people too much. Cool. Any questions on that case? It's actually quite a difficult one because I think a lot of people, when they spot this fragment of meniscus here, because it's closer to the lateral meniscus, they kind of assume that it's come from the lateral meniscus. But it's really important to always, as you did, assess the volume of the menisci and go, oh, hang on, this anterior horn of the medial meniscus is much smaller than it should be, and it's truncated. The inner free edge is lost. It should usually be a bit smaller than the posterior horn, the anterior horn, but in this case, it's way, way smaller. So as soon as you see that, you need to explain it either through a previous partial meniscectomy or a displaced meniscal fragment. And then when you're also seeing that the body of that medial meniscus is truncated as well, you've got to really go and search for that fragment. And there it is, running through that anterior intercondylar recess. It's also worth commenting on the synovitis that's adjacent to this posterior medial aspect of that meniscus, because that often means that it's a symptomatic tear. Because they've got synovitis in that region, so worth mentioning that. When you described the posterior horn of the medial meniscus, you're correct, there's a parameniscal cyst here, and there is some signal running through it. You said oblique, which is kind of correct, but it's best to probably always describe something as being horizontal oblique or vertical oblique. So kind of pick vertical or horizontal as your major orientation. In this case, it's very much a horizontal tear, isn't it? So I describe this as a horizontal tear, posterior horn of the medial meniscus with a small associated parameniscal cyst. That's almost certainly degenerative. It's classic site and appearance for a degenerative tear, and it's obviously been there for a while. It's had time to develop a cyst. I just encourage you to kind of commit to horizontal or vertical rather than hedging and just going for oblique. There's a picture of a bucket handle tear of the meniscus, but our case would have just stripped around to the body and then it's disconnected, and then you've had this bit just flip right across the recess at the front there. This is just a normal MRI knee, just on the sagittal PD medial meniscus, just showing you, 3 complete bow ties of meniscus as you come through on the sagittal. Our case only had 2. And then that nice sharp inner free edge of the anterior horn of that meniscus, nice and triangular. That's what you want to look for. If you don't see that, then look for displaced meniscus. All right, next case. So 35-year-old female again, 3 days of left foot drop. So someone going to have a look at this one?
Yeah, I'm going to have a look at this one.
Excellent. So do you want PD or PD fat sat?
Yeah, we start with the PD fat sat.
Okay. And what anatomical structure do you want me to track in a patient with foot drop?
I'd like to look at the common peroneal nerve from its origin down to the fibular head, because this is a common location for entrapment.
Great, so I'm following that there.
So there's some high signal in the common peroneal nerve, just as it passes the fibular head.
Mm-hmm.
There's also some high signal around the fibular head in the region of the biceps femoris tendon.
Yeah.
But there's no mass or lesion in that area that looks like it's impinging the nerve.
Great.
And I think distally the nerve regains normal signal intensity. This would be in keeping with a neuropraxia of the common peroneal nerve. Given that high signal around the biceps tendon, there might be a biceps tendinopathy as the cause, given that there's no lesion or evidence of impingement.
Excellent. Good. And icing on the cake, what would you look for down on these slices down here in the setting of a foot drop?
Oh, look at the signal of the muscle.
Yeah, exactly. So you'd be looking in this anterior compartment to see whether there's any signs of denervation edema. There isn't in this case, so they haven't actually developed any denervation edema. But I agree, your description is correct. So when we follow from the top here, we've got, we've already divided our sciatic nerve. So we've got our tibial nerve here, and here's our common peroneal nerve coming off. And if we look on the fat-saturated ones, you can see that they're a very similar signal up the top here. So here versus here. But as you come down to that next to the biceps femoris, distal biceps femoris tendon, it becomes very bright, a little bit thick. And the tendon itself is very striated in appearance. It's got intrasubstance delamination or longitudinal splits within it. So there's tendinosis and partial tearing of that biceps femoris distal attachment. And that's almost certainly the cause for their neuritis, secondary to localized inflammation from the biceps femoris tendinosis. There may have been local trauma to the area that's disrupted that tendon. It's hard to know. I can't see any contusion in the subcutaneous tissues, but there may have been a history of trauma. But I liked what you said. You're looking first for an intrinsic lesion of the nerve. So is there any expansion of it with a nerve sheath tumor? You're looking for any extrinsic effects on the nerve. So in this area, what particularly would you look for as an extrinsic cause for impingement of the nerve?
Like a ganglion?
Yeah, so a ganglion coming out of the proximal tibiofibular joint often gets in the common peroneal nerve and follows it up or down. So looking for that. And what else as an extrinsic cause?
I guess any sort of osseous abnormality, so any like osseous lesion or outpouching.
Yeah. So like a classic bone lesion at that site, which is growing outwards, would be
like an exostosis.
Yeah, exactly. An osteochondroma would be the thing. So you look for an osteochondroma, look for a ganglion, look for a nerve sheath tumor. None of that's happening in this case. In this case, there's just localized inflammation due to the tendinosis. Look for the denervation edema. If you don't see anything on your MRI of the knee in a patient with foot drop, where else could the cause be?
From the lumbar spine.
Yeah. So like anywhere from L5 nerve root, which is the main thing that does the foot drop, anywhere along the sciatic nerve, so coming out of the pelvis, and then common peroneal nerve, which is what we're looking at here, and then it can also just be the deep peroneal nerve would cause a foot drop as well, so a bit further distal to this. And I think we covered all this already. So look for, on your knee MRI, you're looking for the nerve signal and size. In this case, it gets a bit swollen and hyperintense as it gets down to that area of inflammation. Look for any ganglions, intrinsic masses like a nerve sheath tumor, extrinsic causes, as you said. Look for that ganglion. Look for the osteochondroma. Signs of localized trauma or inflammation, like in this case, and then assess for the denervation edema. All right, next case, 55-year-old male fell on knee after sudden twisting whilst caring for grandchildren. All right, starting with the plain film, just the frontal projection.
Okay, so frontal projection of the left knee demonstrates a complete transverse fracture of the patella.
Yep.
And there's separation of the fragments. I note also there is this impression of a lucent lesion that is extending through both parts of these patellar fragments.
Yep.
Possibly a sclerotic margin seen at that superior fragment. But it's relatively well defined on this solitary projection. So again, on the lateral, confirming the separated fracture fragments with that lucent lesion, which I think has a very narrow zone of transition. There's no periosteal reaction. There is some soft tissue swelling, which would be incompatible with a hematoma seen in between the fracture fragments. So I think this is a lesion that has non-aggressive features, but we have a pathological fracture associated with it.
Okay, and what do you think the most common kind of pathologies might be?
Non-aggressive lesion, lucent lesion, would things like an aneurysmal bone cyst, a GCT, a giant cell tumor, and then there are still the malignant causes that can cause this appearance, like Mets, myeloma, lymphoma in an adult patient.
Yep, that's a pretty good list. Chondroblastoma is probably the other thing that can occur in the patella and look like this. I've got a CT. So this actually wasn't recognised on the plain film, and so they actually just went and had it fixed with K-wires and cerclage wire, and the orthopods didn't realise that there was a underlying lucent lesion in there at the time. And then they had a follow-up MRI. Just with the plain film, I think the term distracted is quite a good term to use whenever you see a fracture that's separated like that, particularly when you've got opposing forces pulling on it. So try and use the term distracted. All right, let's have a look at the MRI. So here's the T1 signal. And here is the T2 fat-sat signal of that lesion.
So it has quite a high T2 signal, intermediate T1.
Yep. And here's the post-contrast fat-sat.
So it's a bit difficult because the pre-contrast T1 didn't have any fat-sat, but so I'm not entirely sure if this is homogeneous enhancement or not.
Yeah.
But it's definitely not vividly enhancing.
Yep. But it's possibly enhancing, isn't it? I agree. You'd like to see some pre-contrast T1 fat sats to know whether this is definitely enhancing or not. And to be honest, even fluid can enhance if it's synovial and it excretes fluid into the. You can see that in the knee joint, you've got quite a bit of fluid that's already leaked out into the knee joint fluid, the synovial fluid, just from the lining of the joint. So assuming this looks like it probably is an enhancing lesion in there, and it's got no real edema, it's got a narrow zone of transition and probably that sclerotic margin as we saw on the CT and the plain film. So does that help you narrow the differential, or still pretty similar?
I'd probably favour a GCT over an aneurysmal bone cyst.
Yes. What might you see in aneurysmal bone cyst on MR that really helps?
So your fluid levels.
Yeah. Yeah, so aneurysmal bone cysts usually have fluid levels, which this one doesn't have. Giant cell tumours can have them as well because they often arise within an aneurysmal bone cyst. But yeah, the lack of fluid levels and the apparent enhancement of the lesion would favour a tumour like a giant cell tumour of bone or a chondroblastoma. And then obviously you're going to throw in Mets myeloma in older patients, only really if they've got a history of malignancy. Would I put that in there? It's because it's a very rare spot for a metastasis. So here's just a summary of patellar tumours. So as you can see, 80% are benign, and giant cell tumour is the most common, which is why I'd probably favour that on that last case. Chondroblastoma, second most common. Aneurysmal bone cyst, as we said, probably going to have fluid levels on the MRI. And then, yeah, metastases can occur there. Here's just another couple of examples from the website. So here's a giant cell tumour, and here's a metastasis. This one looks more aggressive, doesn't it? You can't see the cortex here. It's eroded. It's got a wide zone of transition, so that looks much more like an aggressive pathology. Cool. Any questions on that? Here's Paget's disease of the patella, just to remind you that Paget's can occur in there as well. So very much looks like Paget's everywhere else, sclerotic, cortical thickening, prominent trabeculations. And then here's a dorsal defect of the patella, so a lucent lesion in the superior aspect of the patella. These are filled with cartilage, so just don't confuse that for a bone tumour. And then the other thing I would mention is gout. So gout deposition around the quadriceps tendon or patellar tendon can quite commonly cause a lucent, punched out erosion of the patella itself. So if you're seeing a lesion, a lucent lesion of patella, don't forget, or maybe this is actually crystal deposition around the patella itself causing the apparent lucent lesion. Another 35-year-old female with acute knee pain and effusion.
So alignments, anatomical, there's possibly some lateralization of the patella, but there's no appreciable acute fracture or abnormality. So have a look at the lateral images to see if there's an effusion. So lateral images confirm the presence of a joint effusion.
Yep.
Yeah. But no associated osseous, no acute traumatic osseous injury, and I'd routinely further characterised with probably an MRI in a young patient.
Yeah, particularly when you're in an MRI tutorial. So I'll also just draw your attention to, in retrospect, after looking at the MRI in particular, there's just a little bit of soft tissue swelling out here, isn't there? It just doesn't look as clean over this side. And then when you look on the lateral, normally Hoffa's fat pad looks pretty clean in this superior area here, but it looks like it's got some density to it. It's not nice and black like the rest of the fat pad. So in retrospect, there is a little bit more than just a joint effusion on the plain film, but let's head along to the MRI now, starting with the axial PD fat sats.
Yes, so this confirms the presence of a large joint effusion.
Yep.
Also in the Hoffa's region of the Hoffa's fat pad where the soft tissue density was seen on the plain film, there's a predominantly low signal lesion with sort of more hypo-intense internal foci.
Yep.
It's reasonably well defined, and it's within the Hoffer's fat pad, and it's also low signal on PD and T1. Given this appearance, I'd favour this to represent focal PVNS.
Yep.
There's no synovitis to suggest diffuse PVNS.
Yeah, so it's the localized form of PVNS, which is pigmented villonodular synovitis. And what does that actually represent?
Sorry, what was your question?
What is the pathology for PVNS?
I'm just thinking.
Like, is it a actual neoplasm or not?
No, so it's very similar to the giant cell tumor of the tendon sheath. They're thought to represent the same pathology.
Yeah.
It's a benign lesion where there's abnormal sort of hemorrhagic tissue. I know that they can have malignant transformation, but it's quite rare.
Yeah.
I think it's yeah.
Yeah, I think it's still correct to probably describe it as a neoplasm, the PVNS. When you look at the rest of this joint here, see in the suprapatellar pouch, see these little frond-like things coming out here. So this is on T1, they look bright, and then on the PD fat sat, they look dark. See those things? What do you think they might be?
I think that probably is more PVNS. I think that's
PVNS
probably
would PVNS be bright like that on T1?
Oh, sorry, it was bright. No. So I think that is synovitis.
Yeah, and it's quite fatty. So I think this is probably some reactive lipoma aberrescence. So sometimes you can get a primary pathology, which is a lipoma aberrescence, where you get these fatty proliferation in the synovium. But it's also quite common to get it as a secondary phenomenon, quite common in patients who have very degenerative knees. You'll often get these frond-like fatty projections in the suprapatellar pouch. So there's definitely a couple of synovial things going on here. There's the localized PVNS, and then there's also a bit of lipoma aberrescence up here in the suprapatellar pouch. The cartilage, what do you think of the patellar cartilage on this one?
Yeah, there's some focal thinning of the patellar cartilage with some fissuring.
Yeah, isn't there? There's
probably it does extend down to bone.
Yeah, there's some superficial fibrillation, but then there's also a small focus of subchondral marrow edema there, suggesting that it probably gets down to the subchondral bone plate. There's other areas here of altered signal. So yeah, it's not all happy, that cartilage. Did you notice another area of marrow edema out here? In the medial femoral condyle, that's probably due to a loss of cartilage here, so some cartilage is probably lost, and then you've got some subchondral marrow reaction. So once you see that, have a good look on your other sequences to see whether there's any cartilage there. You can kind of see on T1 there's a little bit of low signal focus there, so maybe it's a bit of an insufficiency reaction that's going on out there, but that seems to be a separate thing to the PVNS. That may be the thing that is symptomatic though, because often marrow edema is very symptomatic and causes the patient to present, and perhaps the PVNS itself is more asymptomatic.